All right, welcome back, everyone. For those coming back in the room, we're going to go ahead and start the next set of presentations. And in this next presentation, we're going to discuss the impact of healthcare costs on employers and their employees. My name is Christan Royer. I'm the Director of Benefits at Indiana University, as well as Chair of the Forum. And I'm excited to kind of give you just a little bit of information about IU and our data and what we're seeing before we kind of jump into the panel discussion. You know, Gloria said we've got a lot of different perspectives that we're going to be talking about today. It would be nice to see kind of what some employer data looks like. So we wanted to kind of give you a little bit of preview of that. So before I jump into that, though, I do want to say thank you to all of our panelists who have traveled to be here with us today. And I think when we get to some of the questions, are going to bring some unique perspectives about what folks are doing in other organizations in other states and how they're impacting change. And so here with me on the stage, I have Hassan Assar. He's Senior Vice President of Total Rewards for U.S. Foods. And I have Kathy Donaldson. She's Chief of Health Plan Administration Division for CalPERS, so the California Public Employees Retirement System. And Dawn Kopax, she's the Manager of Healthcare Plans from General Motors. Thank you, Dawn. And then at the very end, Nicole Williams is joining us from Cummins, where she is the Global Clinical Director of Strategy. So again, just wanted to take you through kind of a few slides to talk about what we've been talking about today and really turn it over to this panel of experts to talk about what they've been doing in their organizations. So, you know, we've been talking a lot about what's been going on across the country. Suzanne, in her keynote, really, you know, talked a lot about what she's doing in her organization, and we keep seeing all sorts of articles and data and surveys in the news about the cost of healthcare. So, you know, this is becoming more common in the news. And this specific article talks about family leverage level coverage for healthcare premiums approaching $20,000 per year per employee in 2018. And this does not include things like deductibles, co-pays, out-of-pocket amounts that employees are going to pay on top of the premiums that they're paying out for their employees. And so Kaiser Family Foundation, it's a survey, national survey many employers participate in. Probably many of you in this room, like IU does, participates in this survey. And so when we go and look at the data every year, we continue to see this growing trend in employer premiums and employee contributions as well. And so this is just data that we've been watching over the years and trying to figure out how can we keep our costs down, and even though these costs are still rising for both the employer and the employee. And we hear it from our employees. I remember back when I started at IU probably close to 15 years ago, and I paid $1 a month for healthcare, $1. And I remember our phone ringing off the hook about 2 or 3 years later when we raised the premiums to $5 a month. So we went from $1 to $5 and phones ringing off the hook. And today, and we'll show some data here in a few slides, our employees are paying hundreds of dollars a month. So just in the course of 10 years, we've gone from $5 to hundreds of dollars. And so we hear from our employees the struggles they face when they're trying to pay for their health care. And, you know, we talk a lot about internally how can we make sure we're compensating our employees? How can we retain top talent? You know, we're a university really relies on getting the very best and brightest faculty to come to the institution for teaching, research, scholarly articles, all that type of work. We want to retain that talent internally. We want to be able to provide salary increases, provide them a really robust benefits package. And across the country, this is also from the Kaiser Family Foundation survey, we see family health care premiums continue to outpace what workers are making and what the cost of living and the inflation is. And so that's just a growing concern for us. And so these are really just, you know, what's happening across the country, some of the things Suzanne's organization is monitoring. But at IU, we're really taking a really, pinpointed look at what's happening in our population. We're largely centered here in Indiana. We do have some employees that are out of state, but 94 to 96% of our employees are located here in Indiana. And these are numbers on the screen that we publish publicly to our employees every year when we publish our premiums. And we let our employees know what our average healthcare budget is. And so we track that over time. And I think the thing that's really starting to concern us is just the pace at which our healthcare budget has to grow to be able to cover the costs of providing healthcare for our employees. 35% in 4 years. That's rather staggering. And so we're trying to get a hold of that number. When we look at total compensation, it's a large piece of our budget. Healthcare has been a relatively small piece of that. It started at just a couple percent many, many years ago. Now it's grown to 8% of the overall university budget. And so that's a number that we're continuing to monitor. As I mentioned earlier, we hear it from employees, right? So they used to pay $5 a month or $60 a year. And now we've implemented salary banding. And so in an effort to keep employee premiums affordable, we've had growing healthcare costs. We introduced about 5 or 6 years ago premium bands, and we have 7. So what we try to do is we try to make sure we take care of our lowest compensated employees and all the way up to our highest compensated employees, and we're kind of spreading the premium among that group. But budgets are limited, and so even for the lowest paid employees, they're continuing to see increases. And in this example, we have an employee that makes $40,000 a year. We've recruited them, along with 90% of our employees, to be enrolled in a high deductible plan. So we've been really pushing high deductible plans and consumerism. And they have family coverage level. And you can see over time that this is data from 2013 to 2018, that's a premium increase of over 52% during that time period. And as it sits today, 5% of the employee's base salary goes to covering just healthcare premiums. That doesn't include any out-of-pocket amounts for deductible or any type of co-pays and other expenses they have. So we started to look at, well, what is our per employee per year cost? And you can see in the dark blue bar what employees have paid, and in the light blue bar what IU has paid. And you can see that over the last 4 years, that's also increased 30%. So employees are paying more, IU is paying more, and it's just not a sustainable situation for us. During the same time period, I would probably note that we didn't really introduce any new benefits, but we did increase premiums. We did increase deductible and out-of-pocket amounts. We lowered contributions from the employer to the employee into their HSA account. So we tried to use those levers over the same period of time to control costs, and it didn't help. Our costs continue to grow at alarming rates. We did add some headcount, but it was a really small number. It was maybe about 2% on average per year. So we're not adding a whole lot of people, but we're adding a whole lot of costs, even though we're trying to change and tweak the levers as we go over time. This is some actual information from IU data, and I think the thing that is important to note here is the blue line at the top is sort of our average healthcare trend. So our trend has been around 7% for over the last 4 years in terms of healthcare costs increase. But during that same time, the university only gave an average salary increase of about 2% to its employees. And in some cases, inflation outpaced the salary increase, and in every case, the healthcare cost outpaced that. And, thinking back to what Chapin said just, 20 or 30 minutes ago, one of the things that has been the biggest driver of our expenses has been the outpatient facility costs. So you can see over time that the cost of outpatient care has increased by 70% on a per employee per year basis. So this is, again, the leading driver of increases for IU and what in turn gets paid for out of our budget to cover healthcare costs for employees and employers. This aligns exactly with the data that Chapin presented in the RAND study, and this is specific to Indiana data as well. So you can see that this is a huge concern for us. So just at a high level, what is the impact then on these rising costs for employers and their employees? Well, they're a huge portion of our budgets. Costs are growing rapidly on per employee per year basis. It's at rates that are far above the cost of living and something that we cannot continue to sustain. It limits the ability for us to provide raises to our employees. Up until now, to sort of shield IU employees, we've tried to shift costs around and cover that out of the employer budget. That's becoming harder to do, but there's really not much room to pass it back to the employee. If you think back to the slide where I showed a $40,000 paid employee having to cover their entire family, paying over $2,000 a year just in premiums, there's not a lot we can do in terms of cost shifting back to the employee. And so when I start to think about, well, what can we do? What levers are there to pull? We can't keep really doing the same things we've always been doing and expect different results. We're really nearing the end of our ability to improvise with the levers that we've always had, and we're going to have to start being a little bit more creative in what we're doing. And so, we talked a bit about we're increasing employee premiums. We're changing the way we fund or seed health savings account. I know a lot of my peers, I reach out and talk to them often. They're making changes to those things, coverage levels, deductible and out-of-pocket maximums. But you can see from the data in the RAND study, you can see from just little snippets of data from a real employer in Indiana, that's not working. And so what I wanted to do is have our panel really talk about what are some of the things that we can do in the future and really get that discussion started. And as we go throughout the day and have the breakout sessions in the afternoon, gather more and more information about how can we change the cost curve, how can we really impact the cost curve, and what can we do in the future, what levers do we have to pull, and what can we adjust going forward. And so with that, I'd like to turn it over to our panel, and I'm going to ask them each, starting with Hassan, to maybe just give a brief introduction about you, your organization, kind of an idea of where you're located. Some of you are more centrally located, some are across the country, and just give the audience maybe a flavor of a little bit about you.
Sure, thank you for having me. Hassan Azar, I work at a company called US Foods. Every day we move about 10% of the country's food around in 10,000 semi-trucks. You may have seen them around here, and we may have eaten some today. Our population is it's a mixture. So we have obviously a lot of truck drivers. We have a fair amount of warehouse workers. I call them the young invincibles. And we have a lot of corporate employees, obviously, like myself. So when I'm managing benefits and even designing pay, I have to look at the three populations differently because they all have different needs. So I've been in the benefit space for a while. But I have a sympathetic understanding for hospitals and health plans because I've worked at both. I started my career managing hospital clinics, finding market share and creating revenue. Then I went to a health plan to do the opposite. And now I'm on the other end of the dollar, trying to hold on to it as tight as I possibly can. I'm the son of a physician, and my mother was a hospital administrator, which was explained why I went to law school. So, but I...
Thank you. I'm Kathy Donison. I'm the Chief of Health Plan Administration at CalPERS. I've been there for 17 years. I joined CalPERS in 2002, and for the first 8 years, I negotiated health plan rates during a period in which we had seen some of the highest in the past 20 years. After that, I was promoted to Chief of the Health Plan Administration Division and went over and negotiated health plan contracts. CalPERS has 1.5 million lives in the state of California, also outside in the U.S., and some live in the world. We have 1,200 contracting agencies that we purchase insurance for. Those are local governments, schools, special districts. In that mix, we have the active labor force in the state and the local agencies. We also pay for retiree health, or we negotiate retiree health benefits, and we also serve a fairly large Medicare population. We have 7 HMOs, including Kaiser, throughout the state. And then we are self-funded in our PPO plans. We've moved to carving out pharmacy from our HMOs except for Blue Shield and Kaiser, so we manage through a PBM all of our pharmacy. And we also have an employer group waiver plan for our 3 supplement plans. Before I turn it over, want to address Chapin's remarks. We are the plan. We have to decide what we're going to pay for and how we're going to pay for it as we spend $9.2 billion.
Wow, hard to compete with that. Hi, everybody. I'm Dawn Kopaz. And I'm the manager of healthcare plans at General Motors. As many of you know, GM is an automobile company, and we design, build, and sell vehicles under the brand names of Chevy, Cadillac, GMC, and Buick. So we've got about 180,000 employees worldwide, but I'm responsible for healthcare in the United States, where we have about 90,000 employees, about 230,000 covered lives, so nearly 250,000. I've been with GM for almost 20 years now. I've been in my current role for 6 years, and then prior to that, I was in finance, where I tracked the cost of healthcare. So I'm very familiar with the costs, and I can relate to everybody in this room on the rising healthcare costs. I was around when General Motors went through bankruptcy restructuring, in part because of our large healthcare costs and obligations. So coming out of bankruptcy, what we did is we structured a lot of our plans. For our salaried actives, we went full replacement, high deductible plans. So we took that, cost shift lever and we pulled it all the way. And that, appeased the CFO for about 5 years, and then, $5.5 billion went down to $1 billion. We shed a lot of our retiree obligation, but that $1 billion continues to grow. And so about 5 years later, we said, okay, what are we doing now? We've shifted. Now, how do we solve this problem? And so we've been on this journey for the last 3 years, and like Suzanne said, healthcare is local, and Chapin said it as well. So we've been looking at, the top 10 largest communities in which we provide care to look at community-based solutions that made sense for our employees, that encompassed both cost and quality of care. And so I'll be talking a little bit more about a solution that we came up with in Detroit, Michigan, where we're headquartered in Southeast Michigan, a direct contract that we have with a local health system.
I'm Nicole Williams. I am with Cummins. We are a global company. We have about 60,000 employees globally. We are a very diverse company. More than 50% of our population is not from the U.S., and so healthcare and wellness is very unique with us because everyone comes from different cultures and backgrounds, and there's a lot of regulation and governmental oversight with regard to how we administer our healthcare plans as well as our medical services that we're giving to our employees and our families. One thing about Cummins that I'll talk more about as we go into these questions is we have evolved. We know that business is no longer as it once was. It is not business as usual. And our expectation from a health and wellness perspective is that we are evolving, we are elevating, and we expect our TPAs and our hospital organizations, as well as community providers, to evolve and elevate with us in partnership.
Nicole, since you have the mic, actually, let me ask you the first question, especially because I know even though you're a global company, you have a large portion of your population here in Indiana. You just saw the results of the RAND study that Chapin provided earlier. Kind of what are your initial thoughts? What are you thinking about the reaction to this data?
So automatically, I want to say kudos to the 2 providers who stood up earlier and expressed their thoughts with regard to quality health care. Cummins is specifically going after quality first, then cost. And we define quality. a lot of times quality is not really defined. We define quality as improved health outcomes for our employees and their families. And so when it comes to the study and the results that we saw, we really are looking at, in 2019 and even in 2020, how we are going to steer our employees and families to different health care organizations and provider groups. We're also looking at narrowed networks and centers of excellence and how that could help engage our employees and their families in being a part of their own healthcare journeys. And also looking for the best specific, based on geography and cultural, the best specific programs and services that we can offer to our employee populations and their families that would engage them the most.
Dawn, question for you. You know, it's clear employers need to do something different to bend the cost curve, and you mentioned in your introduction some of the work that you're doing in your organization. Can you talk a little bit more about the direct contracting you set up, how that's been working, and sort of what the results have been?
Sure. So it's new. I'll caveat by saying we just launched it 1/1 of 2019, but it's definitely been a journey over the last 3 years. So we went out to the market and we were looking at specifically our data. I came from finance, and we do have a data warehouse internally. So we want to make sure that all of our decisions are data-based decisions, because those have the best outcomes. So from a quality perspective, like Nicole was saying, we want to make sure that the quality ties to our population and improves the health of our population. So not only are we looking to drive costs down, but we're looking to improve quality. And we think the two go hand in hand. If we can get people to the highest quality care, then we can realize lower prices. So we were actually surprised when we went out to the market with an RFP for the health systems in our area, how interested they were in talking to a large employer. We had always been kind of behind the guise of our health plan, and they had done all the negotiating. So they were interested to hear from us as a large employer what needs that we needed fulfilled. And so we had, our market in Detroit is a little bit different than it is here in Indiana. We had 6 health systems, large health systems in the area. We had 3 of them come together as a combined organization to bid on our business, and so that increased their access. But then we had 2 other health systems that also bid. And they were all very excited to submit. But what we had is we dictated the terms. We knew from a pricing perspective, we knew what our costs had been, and we knew where we wanted to get to. We want to get to 0% trend. So how do we get there? We get there by working with our health system, by providing them data that they were not getting from the health plans that's specific to us. We provide them targets, not only from a finance perspective or a cost perspective, but also from a quality perspective. So we looked at 20 areas of quality that we really wanted to improve. Like Suzanne said, C-section rates, not best in class. So if we're at the 75th percentile, how can we get to the 95th percentile over the next 5 years? We have a major issue with emergency rooms. So how can we get people out of the emergency rooms and into the primary care? And having those dialogues with a health system. The employer carries a lot of weight. We provided an incentive for people to choose this plan, to go to this particular health system and to stay within that health system. And so that was what we provided in terms of an employer, but the health system has a lot to provide as well by keeping them within the health system, helping them navigate the care. They have a lot of care coordination to provide, so it seemed to be a win-win for all of us. So we'll continue to monitor. We've got up and downside risk starting in year 1. And we thought that was really important, that there was skin in the game, not only on an upside, but also on a downside risk, and that quality was also tied to that.
Kathy or Hassan, I know you guys are both doing a lot of innovation in your organizations. Can you maybe talk to some of the things that you've done in terms of innovative solutions to control costs?
Well, my journey has been long and varied. So you saw the first sort of 8 years of my life with all of those escalating costs. And over that 8 years as I was negotiating, and by the way, we started negotiating in '02 with spreadsheets. but we quickly built a data warehouse to get all of the data at the member level that comes in on claims. We launched that in 2004. The sole purpose was for getting better premiums and getting underneath what was driving our premiums. Between 2002 and down to 2010, we actually went from that 26% rate increase aggregate I told you about to 3% rate increase, and we did it through a number of different initiatives, understanding our population, what was driving our costs. That led to a reference pricing initiative for hip and knee replacement that was followed on by reference pricing for colonoscopies, arthroscopies, and cataract surgeries. From there, we spent 2 years learning whether those were effective or not. We then, in 2014, as I became a contract negotiator, we went from 2 HMOs to 5 HMOs because we opened up our portfolio for competition between our plans. So our plans had to compete with each other. At the same time, we standardized all of our contracts, including Kaiser. Everything in those contracts was not quite identical based on business models, but very much very close to each other in terms of contract terms. We went from process measures to evidence-based measures in our performance guarantees. We also built in capitation on inflation for physicians, hospitals, and ancillary services. Our plans all had to put ASF, administrative services fees, at risk. If they failed, they had to pay us back. And then we did one thing that was very unique in that time period. We took, except for Kaiser, we partially self-funded our HMOs. So it gave us control over capitation, fee-for-service, and third-party administrator fee payments to those plans. And that gave us an even deeper level of transparency on what we were spending our money on. And believe me, administrative waste, we could see it, simply because eligibility and enrollment systems didn't match each other. So we were paying for people who maybe shouldn't have been on our books. Very simple, but you don't see it if all you do is accept a premium increase. So many of the innovations that we will cover a little bit later in the afternoon session will include our redesign of our PERS Select product, which is a self-funded plan. And also, just as an aside, many of the direction of our patients was in the PPO because we pay every dollar that goes to a hospital or a doctor or a DME manufacturer. We actually pay it. And we pay through our state controller's office. So, as I said, we're the payer. We are the plan. And so we pay attention to where our money is going, and that is what has driven many of our innovations. When we get to the value-based insurance design, we'll talk about how we avoided high deductible plans, raised our deductibles, but went in a different direction to incent our members. And finally, we deliver services in 58 counties. And from my statement earlier about primary care, we don't have enough in the northern parts. And we have physicians who don't want to join an HMO panel. So they are remaining independent. Our ASCs want to remain independent. We think there's room for everybody to have a business model, and that's sort of the direction we're going, especially as we try to deliver care in the far north and eastern counties of California. And finally, the Paradise Fire was horrible. We were in a contract dispute with Chico Inlow Hospital. We're going to redirect all of our patients and members to Paradise, where they have a very wonderful hospital. Overnight, that hospital in that town burned to the ground. So it's something I never experienced except as a force majeure element in my contract, but we immediately moved up into the area to start making sure our members had health care.
Thank you. So I'd like to spend the next 3 or 4 hours talking about what I feel about healthcare costs. It's interesting. So I've worked at 3 food companies in a row now. There's no correlation to my diet, but what I've been told constantly is that we can't add a price increase onto our Oreos or bacon or eggs every time a hospital charges us a little bit more money. So my CFO is always looking to me every time I ask for more money and said, no, you got to go find it somewhere else. And American businesses all over the country are struggling with this every day. And I can't do a healthcare surcharge on every product we sell our customers, because I'd start losing customers every day, and then we wouldn't be able to pay the healthcare bill to begin with. So we're always looking for ways to manage the cost. And I remind my team that the triple aim for us, even though it was created 10 or 11 years ago, is still just as important as it was then as it is now. So we're always looking to manage costs. I mean, it's the number one thing I do when I wake up in the morning, start thinking about how much money we've already spent on our healthcare plan, well, after I kiss my wife. And then the second thing I do is we think about, all right, what's the experience for our employees going throughout the healthcare system? What's their experience with their benefits and everything else that they're going to encounter with their families in the medical system? And then we ultimately want to get them to better health. Selfishly, as an employer, we hire people to work. We don't. We want to make sure that they're healthy and that the system is working. We don't like paying for things that actually don't work. Part of my job actually is managing compensation for our 25,000 employees. With that, this week actually we're processing bonuses and merit increases. And every time an employee, a friend of mine, stops me in the hallway and asks me a question about it, I pull out my insurance card and I say, by the way, you're carrying part of your raise and your bonus in your pocket every single day. And it's true, it's the hidden wage, and employers sometimes forget about it, but it is the increase that keeps coming out of employees' pockets every county, company, part of the country. And it's a difficult conversation to have with employees, and I tell everyone, so I would love to pay a lot more bonuses. I would love the merit increase to be a lot more, but oh, by the way, we're paying a lot more for health care. And then my CEO asked me, he said, are all of our employees with chronic conditions actually healthier this year? And I say, no, they're not. So it's a difficult conversation, and benefits people are actually put into a difficult conversation internally. We're trying to do a lot for an American institution that is actually pushed against the wall sometimes. I will say that when I start getting into what's left in our toolkit, employers have been really good at passing on costs to their employees. We've spent a good 15 years or so finding ways to control demand, telling our employees where to go, how to get their health care, when to get it, who to get it from, how much you're going to pay for it, and by the way, we're going to keep charging you more and more, and the deductible is going to get higher and higher. That has, by and large, stopped. If you look at the National Business Group on Health's latest survey, the adoption of high deductible plans for Fortune 200 companies has pretty much hit the wall. No one's really looking to keep increasing the cost sharing for their employees. So what are we doing? We're looking at the supply of health care. We're looking at the way where our employees get health care, how they get it. We're looking at digital solutions. I actually spend a lot of time in Silicon Valley talking to about 20 different startups that are finding ways to deliver better solutions for our employees. And I'm focused on 3 different things. So we're focused on engagement. So over the past few years, we brought our employees a number of different tools and services to help them manage care in between visits. And we have to remind our employees that healthcare is not just an address, it's something that's done all the time. So we have a digital navigator system for our employees to make sure they know where to go and when to go, and to connect them to services through a digital platform. We have a second opinion service, so we're making sure that our employees get access to the best health care and a second opinion no matter where they are. If they're in the middle of a rural area and their local doctor can't figure out exactly what's going on with them, or if they have the best course of care, I will pull them out and get their records and actually get them to the most appropriate expert across the country, wherever they are. We have transparency services, so we're always making sure our employees have access to information to know where they can get a lower cost MRI, CAT scan, lab test, anything, you name it. So we're constantly making sure that our employees on their phones, sitting in a waiting room, know where to go for better health care. They can do it for their Blu-ray machine, they can do it for their cell phone, they can do it for a set of tires. Employers are slowly learning how to shop for health care. We're not there yet, but it's a journey. And we're also doing a lot of work with advocacy services. So a lot of jumbo employers have, and I say jumbo, that's not size, that's the number of employees. Big employers, we're looking at actually ways to guide our employees through the healthcare. So I mentioned earlier, so we have a digital way of pushing our employees to the right service and educating them and giving them information for decision support. But we've realized that we need actually live people serving as the Julie McCoy Cruise Director to guide people through the healthcare system. Love Boat? Anyone? Love Boat? Thank you. So we want to make sure that our employees are actually on the phone with a live nurse or health plan coach or advocate guiding them through the service or the course of care before the service starts. We're also making sure that they're going to the lowest cost service, and that we're actually asking the health plan and these advocacy services to actually look at what's been ordered and prescribed locally. So that's a new and kind of burgeoning field. And we're also looking at managing health. So there's a number of solutions that we have to actually make sure that our employees between visits have access to a number of things. So we have remote care for diabetes management. So we have connected devices. I have a third of my diabetics actually with a connected glucose meter at home, working with a company that actually has diabetes coaches, and every day they're nudging them on what to do with their diet, how to manage their insulin, how to manage their glucose, and we've seen amazing results with A1C control that way. We have remote mental health care to actually make sure that employees that probably can't get into a psychologist quickly have access to telehealth or app-based mental health care. And by the way, millennials love it. We've just rolled out a program for remote at-home physical therapy using connected devices. It's the most successful thing that I've seen. Our truck drivers told me that after working 12, 14 hours, they can't get into a physical therapist office at 8 o'clock at night, and they certainly don't want to do it on a Saturday. So we're seeing our employees with back, knee, or hip pain actually doing physical therapy at home with connected devices, monitored by a coach. It has a Net Promoter Score of 92 right now. It has an ROI in the high 4 to 1s, and our employees love it. They love it so much that when I said I'm going to let 100 employees try this at home, we'll see how fast we can reduce their back pain. They were telling their friends so much that 700 of them created a waiting list because they wanted access to the service, because they wanted a better life and they wanted it to avoid going under the scalpel. So we're seeing some great results of different things. We've also rolled out a program for diabetes reversal using diet and monitored coaching of an employee's food habits. And so we're using a diet-based approach, and we have a few hundred employees actually getting off their insulin through diet right now through a pretty remarkable new program. And I bring all these up because employers are relying on ourselves actually to help solve a lot of these things. Health plans aren't working fast enough. Providers, thanks Dad, I love them all. They're doing some great things out there, but employers actually are trying to get ahead of things as fast as possible. So we're looking at innovation and disruption. We're talking to Amazon. We're seeing what else is out there just to see what's coming down the pipe to actually get things done. But lastly, I can't do this without providers. And so one of the main things we're doing is we don't want to exclude providers. We don't want to work around them, but we want to make sure that we're paying appropriately. So we're looking at centers of excellence across the country. I'm working with some other employers developing a regional one, because I don't want my employee in Maine to have to fly to San Diego with their family, because they certainly don't want to do that. So we're setting up regional centers of excellence, and they're tied with bundled surgery payments. And so we have about 90 bundles right now, and I'm working with a vendor right now to actually set up these bundles, and I gave them the mission that if you can bundle anything, bundle it, and we will use it. So that's our way to disrupt healthcare and actually find the best way to control our expense. Just kind of end with a few weeks ago, I had one of those oh geez moments when in our annual call with Wall Street and our fourth quarter results and our talk about our year-end results, the CFO started talking about the high cost of healthcare and how in the fourth quarter we had a large number of high-cost claims, and it took us by surprise that the health plans, the actuaries, that no one had an idea these things were coming. Doesn't feel good sitting in my shoes when I then have to spend 2 weeks talking to Wall Street analysts explaining what we're doing to control healthcare costs. But it is actually a legitimate issue, and when it turns up in our annual report as a headwind, and we don't mention fuel, and we're a trucking company, that's an issue.
Yeah. Thank you, Hassan. Turning it back over to Nicole, can you maybe talk about Hassan's talking about some of the disruption he's making in healthcare with what's going on in his organization. What are you doing at Cummins, and have you seen results from what you're working on?
Sure. I think that, one thing that you brought up, Hassan, was engagement. And I think that's at the forefront of what Cummins is doing, because the way I see it is, unless you can engage consumers into being a part of their own healthcare transformations and healthcare journeys, nothing else is going to happen. You can't make an impact anywhere because people have to be engaged. On the other side of that coin are providers, physicians, NPs, PAs, medical teams. If we're not getting people into those primary care physicians and organizations in our communities first, and giving them incentive to go back to the passions for which they went to medical school and through residency programs for, and making them a priority with regard to their satisfaction in their job, we are not going to move the needle. And so those are things that we at Cummins are looking at very closely. In addition, we're looking at personas. We have a very diverse population of employee cultural backgrounds. We have a diverse population of employee types, shop floor employees, which are the biggest, those are the biggest contributors to our organization. They build engines. They're the ones that bring all the money in and all the revenue. But they're also the most unhealthy population of employees at Cummins. Why is that? These are the people who are working day to day just to make ends meet. And all of us in this room may have forgot to an extent what that's like, right? And so until you put yourself in the reality of what it's like to go day to day, paycheck to paycheck, going home and dealing with those behavioral health issues that your children have and not being able to address those because they can't find the right providers or organizations to take them to, these are the things that Cummins is focused on. We're focused also on finding the right programs and services to engage those employees in the best way possible to make the biggest impact on improving their health. So a quick example, and I will pass the mic, is when we have a plant, Whitakers, North Carolina. Okay, this is a very high-producing engine plant. Majority of the employees there are African American, and of those are men. I know personally from cultural background that a lot of African American men do not like going to the doctor. It's just not going to happen. You can't, until I have to go to the doctor because something's happened to me, I'm not going to the doctor. But I will go to the barbershop and hang out with the people that are a lot like me, and we have a lot in common. That's my safety. That's a good place for me. And there are evidence-based programs out there that actually go to the barbershop to engage this population of people. And what they do is they bring a mobile unit onto the parking lot, and they have people go in there to get their preventative screenings done, and they are talking to them in a way that they can relate and trust and build that credibility. So I think us as healthcare administrators, leaders in the organization, TPAs, providers, until we're vulnerable enough to be vulnerable with them, we won't be able to make the impact that we're trying to make, and that's where we need to go. It's a mind shift, it's a cultural shift, and we all have to do that.
Thanks, Nicole. So we're running a little bit low on time, so we'll end with one maybe final question for you, Dawn, since you have the mic. Just going back to what you described earlier in terms of innovations you're doing, some of the direct contracting, what was your key takeaway from that experience in implementing the new solution? And sort of what is it that you're hoping to do to expand on that in the future so that other employers can see that you're starting small and then continuing to grow it over time?
Yeah, absolutely. So I wouldn't even try to suggest that direct contracting is the right solution for everyone in every market. It made sense for us in the Detroit area because we had the scale that we had, and we had some very willing health systems who were eager to work with us, who had been down this road with Medicare in terms of the ACO model. So they were really, really excited to work with us, and they were ready. So that is super important because not all health systems are ready and willing to work with you. So I would say we're trying that, but we're also trying other things. We're trying, with our carriers, we're trying ACO solutions. that they have. Now, I know that's not specific to GM, and with the direct contract, we were able to pick what the quality metrics were. We were able to make sure that there was up and downside risk in our contract, and we can't do that. But and again, not all of the health plans have ACO models in all areas. So we're also working with other large employers, trying to band together. We've got plants and pockets of people around the country where we may only have a couple hundred or a couple thousand people. So what can we do? We don't have the leverage there to walk into a health system to say, hey, this is what I demand for quality, this is what I demand for cost. And they just kind of look at us and laugh. But if we can find other employers who do have that volume, we have some experience, be it little, to come in and say, hey, this is what we've tried before. Maybe we can work together and we can, come to some type of an arrangement where all of us win in those type of areas. So, and I would also like to mention too that before all of this started, we really started with the employees. We started with empathy interviews in design-based thinking because we sit on the benefit staff and we're smart. We see the data, we think we know what's going on, we think we know where the employee concerns are, but we don't. And so we had several rounds of focus groups of getting out, not just in the Detroit market, but getting out to the plants, getting out to the other areas, working with our employees, going through their experiences to figure out what their needs were and how we could break down those hurdles. Because why we're seeing data that we don't like, there might be reasons behind that data. And there's ways that people want to receive information. There are ways that are more beneficial to nudge them in the direction that we need them to go. So I would say it all started with employee interviews. It started with looking at the regions that we were in. We're trying a bunch of different solutions. We're trying ACO solutions. We're trying direct contracting. We're trying, employer forums. We're looking at other niches. We've got a lot of the programs going on that Hassan says. And we're just trying to pilot these things to see what works, to see what gains traction, and learn from those experiences so we can take them and, work with other employers, take their learnings, and hopefully take this and expand it. Because eventually, we would like to have a high-performing option available for all of our employees. We would like for them to have a plan that says, these are the highest quality docs at the lowest price. We've vetted them, and this is endorsed by your employer. Take it for what you wish. If you don't want to choose that option, that's fine. There's other options. You can go to a broad-based PPO, but it will cost you extra money. So it's, right now trying to knit together what is a national solution so we don't have our employees in Detroit with an option, but when we look at our employees in Dallas, they don't have anything today. So eventually we want to get there, working with other large employers, working with coalitions, working with health plans, working with providers to try to come up with the right solutions.
Great. Thank you very much. This is kind of the end of our discussion, and I hope that you learned a lot, hope that you got some takeaways from this. I know that these panelists are going to expand on what they were talking about this morning. Most of them are in panel or additional discussions this afternoon, so this is maybe more of a little bit of a teaser for what they're going to dive into later today. If you don't mind to help me thank this group of panelists for their time and effort today.